Okay, let's start. Welcome everyone to the bi-weekly seminar series that we are organizing under the Expeditions Project. We have about 27 participants, which is excellent. This is the third seminar in our series, so it's fairly new. And I appreciate folks joining. We have two terrific seminars that we have heard so far. The first was by Simon Levin and a student, Dylan Morris. The second one was given by Rita Colwell. And third is now going to be given by Alison Galvani and Abhishek Pandey. Again, just like the first two speakers, Alison and Abhishek don't need much of an introduction, so I'll keep it very short. Alison is a professor at Yale, and Abhishek is a research scientist at Yale. Done some tremendous work over the years. Been very impressed with what Alison has done. She was a student of Robert May. Correct me, Alison, if I misspeak these things, but she's done some remarkable work on infectious disease epidemiology and modeling. And it's a pleasure to have her and Abhishek speak today about the work they have done recently in the context of COVID. So Alison and Abhishek, over to you.
Thank you. Thanks, Madhav. So hi, everyone. Thanks for joining in today. It's a pleasure to have this opportunity to share some of our work that we have been doing on coronavirus at Center for Infectious Disease Modeling and Analysis during the last few troubling months. Back in January, when outbreak in China began spreading and some cases were reported in travelers outside China, we began focusing our research on COVID-19 at Sigma. In our earliest work, we evaluated the impact of international travel on the global spread of coronavirus. This followed with some early work on assessing the hospital capacity in the United States. And more recently, we have looked into the contribution of asymptomatic and pre-symptomatic infections towards the transmission. What I'm going to present today is some of our early work, as well as the most recent work that we have been doing at Sigma. Let me begin with a brief timeline of the COVID-19 in the United States, leading to the question that we tried to answer. The first case of COVID-19 in the United States was confirmed on January 21st in a man in his 30s from Washington state who developed symptoms after returning from Wuhan. 9 days later, the first case of human-to-human transmission in US was reported in a husband of a woman from Chicago who had traveled to China and returned, and her husband developed symptoms. On February 26th, CDC confirmed an infection in California, which actually represented the first US person to contract the virus, despite not visiting any foreign country or coming in contact with any infected patient. So at this point, the number of COVID cases that were detected in the United States stood at 15. Just 2 days later, it was known to us that test kits CDC had sent to states were flawed. CDC announced that it has taken steps to address the problem with the flawed test kits. Also, till now, there was only limited testing available, and only through CDC. Moreover, testing criteria restricted the testing to only individuals with known travel history and those with specific symptoms. From this point onwards, CDC also expanded this criteria for the coronavirus testing. The very next day, US reported its first death outside the Seattle. Months later, autopsy findings have now revealed that 2 people had actually died due to COVID as early as February 6th, indicating that community transmission must have been occurring there much earlier than it was believed. In less than a month from the first reported death, US surged past both China and Italy to become world's most infected nation on March 26th. During this time, there was growing concern that the surge in the number of cases will overwhelm the healthcare system in the United States and locally and at a much bigger scale. As was being seen in New York at that time too, it was troubling everyone that weeks before the actual epidemic, in this figure I'm just showing this for illustration, that weeks before the actual epidemic peak reached in New York, on March 26th, according to the New York governor's office, there were only 307 ICU beds available in New York City and a little over 1,000 in the whole state. Fortunately, the urgent expansion in capacity, along with stay-at-home orders, enabled New York to avoid hitting the surge capacity. While all this was happening, in our early study, we tried to understand what the situation could look like throughout the United States. To do that, we developed an age-structured mathematical model for coronavirus transmission and parameterized it with the US demography. The model compartment that we used followed the natural history of the coronavirus infection, and the rates were parameterized based on the best known estimates for the parameters that we had from literature at that time. We took this model and we calibrated the transmission model to the initial estimates of the reproductive number, which was 2.5. And we ran simulations to see how ICU bed capacities and ventilators would be needed. What we estimated was that at the epidemic peak, we estimated around 300,000 cases of people would be needing ICU beds. More importantly, most of these people who would need them would be above 50 years of age. Now, this was 3 times more ICU beds than actually the existing number that we know of that existed in United States at that time, which was around 97,000 something, very close to close to 100,000. Now, one more thing was the fact that 65% of these ICU beds in United States are generally occupied at any point of time. So if we accounted for this occupancy, we predicted that the need would be even greater, 8.5 times higher. Using the same model in another paper, we also projected that at the peak of epidemic, we will require at least 40,000 additional invasive ventilators than they were available at that time. This was done at a very early stage of the epidemic. And at that time, none of these stay-at-home orders were implemented. What we did was we simulated disease spread under a range of scenarios for self-isolation, whereby symptomatic individuals reduce their contact within the community by staying at home. What we found was that isolation of cases can ease the burden on the healthcare system, but it depended on what proportion of cases do self-isolate and how fast they can do it. For example, if 20% of the mildly symptomatic individuals self-isolated themselves in 2 days, then peak weekly requirement for the ICU beds reduced by 25%, and the peak got delayed by about 4 weeks. Whereas if they self-isolate in 1 day, then the requirement at the peak would be reduced by 50% and delayed by 12 weeks relative to the no self-isolation scenario, as you can see in this figure. One other thing to note is that even in that scenario, we were still hitting the surge capacity. Now, one thing to note is that we know a lot more about coronavirus right now. So while our results at that time were at national level, so they did not really capture the very important spatial heterogeneities, which several other papers later showed similar results at more granular level. Also, as not much was known about the pre-symptomatic and asymptomatic infections back then, our model did not directly account for them. To some extent, the proportion of mild infections who did not need hospitalization kind of ensures that we don't overestimate the hospitalization. And though including pre-symptomatic, as we did in our later work, I think could have potentially pushed the peak earlier in our estimation as the infectivity of the person shifts based on the current knowledge. So what exactly our results was useful for at that time? So at that time, our results underscored the urgency of expanding the ICU capacity, necessity of mitigation strategies that could accelerate case isolation, such as increasing testing, rapid contact tracing, and population level movement restrictions. If we remember at that time, states across the country were also racing to stockpile ventilators. There was no coordination, and not just ventilators, but PPEs, other medical supplies, as they were preparing for surges in COVID cases in their respective states or in their respective counties. Our results, mainly about the ventilators, also highlighted the greater need of federal coordination on the production as well as distribution of the PPE and ventilators across the states. What happened next? In light of these growing concerns, now we know that most states had issued stay-at-home directive by March 31st to encourage social distancing and to flatten the curve to gain some time for ramping up our healthcare facility. However, for more than a month now, socioeconomic repercussions have fueled the calls for reopening the economy and lifting the social distancing measures. In fact, during the month of May alone, many states began lifting stay-at-home orders and other restrictions on social and business activity that were put in place to curb the spread of COVID-19. As a result that we already are seeing, cases have been surging again in several states, including Florida, Texas, Arizona. US is now in fact reporting highest daily incidence so far with about 50,000 cases per day. In fact, in the morning today, I saw that there was 60,000 cases yesterday. While some of these states, because of this resurgence, are now reconsidering the restrictions, it is unsure if they will go back to restrictions like before. Therefore, in the absence of population-wide restrictions, isolation of infected individuals will be the key to curtailing transmission, at least in theory. However, based on current knowledge about asymptomatic and pre-symptomatic infections, it is important to revisit these strategies that are based on symptom-based isolation alone. What do we know about asymptomatic and pre-symptomatic infections by now? Couple of studies that we used in our recent study as well, I'll talk about. So about asymptomatic infections, there was one particular study that estimated that about 18% of COVID-19 cases on the Diamond Princess cruise ship were asymptomatic. In another study that used the data on Japanese nationals, around 565 of them, who were evacuated from Wuhan, to estimate that the asymptomatic ratio was 30.8%. Clearly, there is consensus that there is a significant amount of people who remain asymptomatic. Moving to the pre-symptomatic infections, there is growing evidence that have indicated that individuals may be most infectious during the pre-symptomatic phase. In a particular, a study that was published recently in Nature Medicine that was showing temporal patterns of viral shedding in these 94 patients in China with confirmed COVID-19 diagnosis, estimated that the peak infectivity occurred around 2 days prior to the symptom onset. So technically what they had found was that 44% of the secondary persons infected were infected around 2 days prior to the symptom onset. Knowing all this, effectiveness of any symptom-based isolation strategy will be dependent on the extent to which these silent infections, pre-symptomatic and asymptomatic, contribute towards the transmission. In our most recent study that actually just got published day before yesterday, we translated this clinical level data on infectiousness and symptoms to population level epidemiological impact. To do so, we extended our previous model to include asymptomatic infections and pre-symptomatic stage, which was parameterized with the data regarding the trajectory of symptom onset and the proportion of secondary cases that was generated in each stage of the infection. And here is what we found. We ran these simulations for both levels of asymptomatic proportion from the two studies. If we assume that 17.9% of infections are asymptomatic, then we found that the pre-symptomatic stage accounts for 48% of the transmission and asymptomatic infections account for 3.4% of transmission. For a greater asymptomatic proportion of 30.8%, the pre-symptomatic phase and the asymptomatic infections account for around 47% and around 6.6% transmission respectively. Now, given that this is really high number, what we did was we said, okay, what would happen if we immediately isolated all the symptomatic cases? So what we found was that even if we immediately isolate all the symptomatic cases, that is going to be insufficient to achieve control. Specifically, if you look at this, mean attack rates remain above 25% if the asymptomatic proportion is 17.9%, and that remains above 28% when the asymptomatic ratio is around 30.8%. Now, this makes things challenging. So clearly, the symptom-based isolation intervention may not be as effective as we think, because even without them, we will have a big outbreak. We try to look at it that given the inadequacy of the symptom-based isolation to control COVID-19 outbreaks, what would be the synergistic impact of isolation for pre-symptomatic and asymptomatic infections? Combined with the case isolation of all the symptomatic infections. What we found was that to ensure that we can suppress the attack rate below 1%, we will need to isolate about 33% of silent infections for the asymptomatic proportion of 17.9%, and about 42% of the silent infections need to be detected and isolated for if the asymptomatic percentage was higher, like 30.8%. So that kind of tells us that we need to actually be testing more people than we are testing right now, and people without symptoms. Just to reiterate, I think results from our this latest study have several takeaways. Silent disease transmission being responsible for more than 50% of the attack rate, and it being capable of sustaining the outbreak alone, even if all the symptomatic cases are immediately isolated, makes the control of COVID-19 even more challenging than it was believed. It also indicates that symptom-based interventions would not be sufficient to curtail the transmission, which highlights the urgent need of scaling up testing of suspected cases without symptoms. This is something which is also noted in the revised guidelines of the CDC. We will also need to identify the exposed individuals prior to their infectious period. And so symptom-based surveillance must be supplemented by rapid contact-based surveillance. It is also worth noting at the end that our estimation for how many silently infected individuals we will need to isolate to suppress the attack rate below 1% is technically conservative, that 33% and 42% of the silent infections need to be detected. That in our mind is conservative for several reasons. For example, the inevitable imperfection in isolating the symptomatic cases would translate into a greater need to prevent silent transmission. Similarly, delays that would occur in contact tracing would increase the risk of onward transmission, especially since those without symptoms are generally unaware of their infection risks to others. Therefore, are less likely to restrict their social interaction. At last, I would like to bring it back to where we are right now. And given that we are back to where we were in March in terms of potentially overwhelming the hospital capacities in some parts of the country, maybe a little bit better prepared to scale up than we were back then. But in both Texas and Florida, many counties have already filled more than 90% of their ICU beds due to the recent surge. Now, our current findings are pertinent in highlighting why we need to aggressively expand testing to people without symptoms, do rapid contact tracing and isolation, and we'll have to complement it all by continuing to social distance. We'll have to keep our schools closed for now and have population level measures again in the most affected regions, at least again. Thanks so much for listening. We're happy to have any discussion or question.
Abhishek, thank you very much. I'll clap. I don't know, you can't hear everybody's clap because you're mute. But this is wonderful. Thank you very much for presenting on your group's behalf. Let's open up the floor for questions. You did very well on time as well. It's useful. Alison, welcome. Do you want to add a few points, Alison, before we take on questions? If you think there are a few points that you would like to add.
Abhishek did a terrific job, so I think he covered all the key points.
Okay, excellent. Great, thanks. So let's open the floor for questions, but I encourage people to ask questions. This is a great presentation. Thanks again. So maybe let me start it off so that people get a chance to think about their questions. So Alison and Abhishek, I think the idea of estimating the silent spreaders is an important one. There are 2 or 3 studies, right? One by CDC, one by folks at Columbia that have also tried to talk about asymptomatic cases. Do your numbers sort of look consistent with their sero testing work that they did, or they're completely different in a certain sense?
Well, some of the so we've also done a meta-analysis of asymptomatic papers, and a lot of them are calling asymptomatic when someone, is positive but doesn't have symptoms. However, a lot of those people progress to develop symptoms, and so unless the study has followed people longitudinally for, a matter of a couple of weeks, they haven't been, in many cases, distinguishing the pre-symptomatic to the asymptomatic. So some of the higher estimates for asymptomatic transmission are actually, or asymptomatic cases, are actually a combination of the pre-symptomatic and asymptomatic. And asymptomatic isn't quite as high as, I've heard there've been some estimates of like 50%, 60%. The two papers that we cited and used for a scenario analysis, which had large sample sizes and did follow cases, they had, 17% and 31%?
Yeah, about.
Yeah. But of course, everyone passes through the pre-symptomatic phase. That's where the viral load peaks. It's really concerning. I mean, not only are people infectious before they're symptomatic, they're more infectious before any symptoms appear. So control measures like temperature checks miss everyone who, missed the most infectious period.
Thanks. Other questions?
Hi, thanks for a very nice presentation. I might have missed some parts in between. My question is with regards to the role that contact tracing has played with regards to the data that you have used. Can you shed some light on that? How much effective has the contact tracing been in coming up with some of the results you mentioned with regards to symptomatic and asymptomatic percentage you showed with regards to how much you require and so on?
So in terms of did not directly assume that this is going to happen only through contact tracing, but I think contact tracing would be part of it. So I went back to the slide where I was talking about this. What we found was that if our asymptomatic percentage is about 18%, then we'll need to isolate these silent infections, basically trying to find the asymptomatic cases and the pre-symptomatic cases, about 33% of them. So without doing that, and this is when we are assuming that everyone who has symptom or any symptomatic person is isolated immediately after they show symptom. So you have to immediately isolate anyone who shows symptom. And on top of that, you need to find 33% of those silent transmissions, silent infections that do not show any symptom. Now, when you are actually questioned that how effective the contact tracing is going to be, I think that to be able to do any of this, contact tracing is going to be one of the ways that you try to achieve that. For example, anyone showing symptom, you have to actually follow through all the contacts, keep checking, keep actually giving them tests so that in case they become positive, you actually catch them before they might actually become symptomatic. And that way you would be able to isolate it. So to be able to do something like this, contact tracing would have to play a central role. Alison, do you have anything to add?
I mean, Abhishek explained it well. We didn't explicitly model contact tracing. However, we showed that you need at least to capture a third of pre-symptomatic people in order to reduce attack rate to 1% in the population. Yeah. And so basically you would need contact tracing, or else kind of unrealistically, in the US anyway, unrealistically widespread testing every day of everyone. But you would need to do contact tracing, and you need to do it extensively enough and fast enough that you were catching people in their pre-symptomatic phase. So there's on average, there's the incubation period, and it's an average of 5 days. And then the first 3 days, people aren't very infectious. Your viral load is low. And then it's the next 2 days of the incubation period that is being referred to as the pre-symptomatic phase, where your viral load really spikes and then actually declines as you're going into the symptomatic phase. Yeah, I can't see any other way than contact tracing and rapid, extensive contact tracing to find the people within 3 days, basically, to capture them before they enter this pre-symptomatic phase.
Okay, thanks.
Jacob Ritchie's question first, which was, is encouraging mask wearing for asymptomatic people useful?
Abhishek, do you want to answer that?
I would say that yes, mask wearing so the problem with asymptomatic people would be that unless you test them, you would not, those people would not even know that they are asymptomatic. So it kind of translates, without testing, it translates back to saying that everyone should be wearing masks when they're outside or
Yeah.
possible not to go outside.
Yeah, I think that's probably what the question was getting to, that, how much would masks help? I think masks help, keeping a distance helps, but when I don't think there's been enough general communication in the media about the proper wearing of masks, because if people are touching their face, adjusting their mask and removing their mask, they can be transferring the virus from their hands to their face. And there've been the recent COVID-19 studies showing that masks are, have some good effectiveness. So that's definitely helpful. There are some older flu studies that showed in some cases it can exacerbate transmission because of that touching of the face. So if a mask is worn properly and not removed and adjusted a lot during the day, then I think it makes sense that would be effective. Of course, not as effective as staying at home if feasible.
Also, wearing it for a long time, even if you are wearing it correctly, it's really, really difficult. So people inadvertently touch the mask, their face area. It makes things safe, but not as safe as it not going out.
In the news yesterday, we heard how the president wanted for schools to be reopened. The idea that children would wear a mask throughout the school day without touching the mask and also not eating, I guess, because obviously to eat or drink, you take your mask off. It's hard enough for adults to do that. So yeah, I don't think it's a practical strategy for children. And children I don't know if Abhishek mentioned, but children are disproportionately responsible for transmission just because for silent transmission, because they're more likely to be asymptomatic. And they also have more contacts. We used, contact survey data. They have more contacts. Well, I think mostly because of school. So if the U.S. if we can't even control our outbreaks in the vast majority of states when schools are closed, the idea of reopening schools before we have really suppressed the numbers, I think, is reckless.
Yeah, listen, I couldn't agree more. I think this is a challenging time policy-wise. Thanks. I think we have a few more questions online.
We have a question from Irene. She says, very interesting and important work. Thanks, folks. Given where we actually are today, how realistic is it that contact tracing could bring COVID-19 under control? Any estimates of lives that could be saved if we did it right?
We have to suppress our cases dramatically from where we are now to be able to have and we have to have enough resources such that for every case that we're aware of, we need a contact tracing team to descend on that case and, follow contacts and ideally contacts of contacts and test them all and potentially test them all daily. We're so far from that in reality. Sorry, and the question about the saving the second part of the question. Well, we haven't estimated that directly, but certainly that could be done. Comparing the epidemiological trajectory under status quo and then compared with much more extensive and concerted effort to control the virus to get at the lives that would be saved.
Okay, thanks, Alison. I think our next question is from Sankar Basu. What math models are you using? Differential equation-based compartmental models or stochastic models or something else? And could you elaborate on that? Do you have any details available on those things in your papers or reports or websites?
So yes, our base case model is based on a differential equation compartmental model, which is actually divided into 4 age categories. And we used data on, as Alison mentioned a little earlier, about the contact patterns between these different age groups. And we incorporate that as well. Most of the information you could find on in our paper, in our first paper, which is cited in the presentation. I don't know if the presentation would be made available for everyone or the but we would be happy to share the link. So,
right, we're going to, Abhishek, we are going to request you to send it to us. We're going to, we can,
Oh, yes. Yeah,
attach.
sure. Yeah, it's published. Abhishek, I'm correct in thinking it was basically all the papers are in PNAS or Lancet ID. But yeah, they have the methods. And in some cases, we used individual-based models.
Yeah, in the last one, we used like agent-based model as well, but all the information is there. In fact, if you go to the paper, we have, at least in the earlier version, the GitHub page linked to it where you can like look at the code and see. So all the information you would be able to find there. So, we have, I don't know exactly whose GitHub thing is, but it's definitely in the paper. So it's
it's public. Our code's publicly available and described in the methods in the supplemental information.
Our first paper has in the appendix very well written description of the model. So that would be a good place to start, because the other papers use the same model and just change things. So all the changes are described in the other subsequent papers that are relatively brief.
Okay, we have another question from Stephen Eubank. Do data on viral loads include shedding rates? Presumably pre-symptomatic people are not coughing or sneezing.
As far as I remember, reading this, they did have, so they were actually being followed through and monitoring them through throat swabs, so every day. And so I remember seeing one figure where they have these temporal patterns of viral shedding in there.
Yeah, that's what they described. It's viral shedding.
Yeah. So for, I think, more than 400 throat swabs were collected at different point of time for 94 patients. Yeah.
Based on the plot that's being shared right now, so we can see that about 46% of isolating silent infections, that given range, we can about get the attack rate below 1%. Do you think if there's a way to estimate how many silent infections exist in the population so that 100% lockdown isn't, so that overwhelming strategy can be lowered to bringing, let's say, if we get 60% of the total population isolated, that should be good enough, or something which is not a complete lockdown, but based on the methods that you've used in this plot?
Well, it makes sense that if you're locking down, so as you're saying, you wouldn't need to necessarily lock down the entire population to reduce this attack rate. So if you're doing an indiscriminate policy like that, which I actually think makes sense, because as we were just talking about with the contact tracing, given the current numbers, isn't feasible. Yeah, it would make sense. If you're locking down 40% of the population, you should be also getting 40% of the silent infections. Although you have the complication that here infections are more likely to be in the over time in the population that's not locked down. So you'd have to do a kind of, if you did a shifting, everyone took turns being locked down, then I guess that would be a widespread way of getting around that sort of bias that it's the people not locked down who are more likely to get infected. So, but I think also when we talk about just lockdown so in practice, I don't know how you would do a 30% lockdown of the population, but even when we have a full lockdown, we're still allowing, and we need to have society run. We still have our essential workers out and about. So, and I'm not sure I don't know if anyone else knows, but what percentage of the population that corresponds to? I mean, 10, 20%, probably not more than that. Yeah, essentially, I think that even though it's, everyone is tired of the stay-at-home orders and they have economic impacts, it's kind of a false choice, I think, over the long term anyway, between economic choice and public health, because, people getting sick and their treatment and the death also has economic ramifications as well over the long term. So I might be going off a bit of a tangent on that, but so I'll just stop there.
Yeah, thank you.
Hi. Yeah, no, it's just a comment. There have been several questions about the efficacy of quarantine or contact tracing and testing, perhaps even. And I was just going to comment that Alison and I have some well along analytical research on this topic, and hopefully we'll have some more precise answers on that soon.
Great. Anil, can I prompt you to say a few words about the work you are doing that relates to resource augmentation, which connects to the work Alison and Abhishek presented?
Sure, yeah. So I guess maybe one main thing is we're looking at sharing between the healthcare units, so either within hospitals or HRR regions, so various levels of aggregation, and we find patient transfers or resource sharing seems to help in reducing the total burden.
Yeah, because I think they point out they have some good initial results, and perhaps we could talk to them further afterwards. So Jeff, maybe you can tell us, you've given us real teaser, I guess. Can you describe what kind of results you expect to obtain from the analytical work that you're doing?
Just essentially estimates of the R0 based on any program of contact tracing, quarantine, and testing that someone might apply.
Okay.
Or are effective, I should say.
You want to give a take-home message, Jeff, related to that?
Sure. The results that I have so far basically, say that it's very important to do it's all like the probability of someone getting through a quarantine or the probability of capturing all the individuals who have been contact traced. And I guess the comment that I'd make relating to the question that was asked earlier about contact tracing, and this was said, Alison said this, but just to make it very, very clear, one of the issues is that if you do the contact tracing, you need to do the contact tracing really quickly in order to make sure you get the individuals who are pre-symptomatic, right? And because the infectious period sort of launches up very quickly at around 2.3 days or so. But the issue is if you do it too quickly, you may test them while they're still in the latent phase before they actually have that exponentially increasing viral load that actually gives you a positive RT-PCR result when you do a swab. So you're stuck in this situation where it's very hard with a single test to actually really strongly inform you about individuals who are asymptomatic or pre-symptomatic. And so it really is it's an intricate question, but it's one which we can answer, and we're well on our way to answering it. But you just have to consider all of these possible phases of this disease. And I guess the caution I would say is that there's been a lot of talk about the efficacy or not efficacy of testing, et cetera, the false negative rate, et cetera, et cetera. And I think in general, it's very important to consider the time scale of the disease, like when is the person in disease when looking at these things. And the results have been published that show this. That's not really exactly new, but you still see studies that say, oh, the PCR test has this efficacy without reference to when in the disease time course it was used. And I think without reference to when it was used, it's a meaningless percentage.
Well, overall, it's like 70% reliable. That's actually, what Jeff was referring to is why I was saying, we ideally need daily testing because 70% overall, but it's much lower like the first 3 days of the infection, in the incubation period. And then actually, the good news is that because the pre-symptomatic phase, the viral load shoots up, the test is more reliable during that phase. But then again, because it's only a couple days and people are transmitting a lot, we want to also catch them during or before, ideally before that phase. Yeah, we could test someone on their second day of infection and the test could easily, quite possibly come back with a false negative. And then, the effectiveness or the reliability of the test, sensitivity test, actually starts dropping off during the symptomatic phase. I mean, you've probably read about these, cases where people are really sick or, even like just before they die, they're testing negative for the virus, which actually I think might relate to death being caused by like cytokine storm and kind of immune system, less directly damage from the virus and more overreaction and inflammation of the immune system, inflammation of the hearts and lungs. Just adding a bit more detail to Jeff.
We have one more question in the Q&A box from Sylvia Spengler. Is the latent period approximately 3 days for the PCR test?
The latent period for the PCR test? I'm not quite sure what that means.
Sylvia, do you want to elaborate on your question?
I would assume that the question is the latent period for the disease about 3 days in which the PCR test is...
It's a false.
Yeah,
Oh, right.
false negative. That's approximately right.
I'm trying to get an idea of balancing essentially a silent test period, which when you're super contact tracing, people try really, really hard. You know, you get a name, you go after them, you test them, it's within 48 hours. What's the chance that they're just negative even though they're positive because you're in the latent period, I guess is what I'm trying to get at.
Yeah, that can definitely happen. I mean, we want to do it quick. This is why it's so challenging. We want to do it fast enough that we find people before they're in the pre-symptomatic phase, so we can't wait.
And shedding like Pigpen.
Right. But if we do it so fast that we catch them, you know, within 24 hours, then quite possible the test will come back with a false negative. So, you know, ideally we find them quickly and then we test them every day.
Yeah, at least isolated.
5 days would be, the 5 days would then cover the incubation period and the pre-symptomatic phase. And so, I mean, even longer is fine too, but that would be, I think you get most of your effectiveness for reducing transmission with that kind of a strategy. So the idea that, we just need, be like, how many of our population per capita have been tested? In some cases, we need, you know, multiple tests per person, per contact, not just one test.
But your question is right on. I'll just comment that that's exactly what the kind of calculation that we're working on right now and have some results on, but we need to, you know, get them together in a coherent fashion before we can present them. But yeah, that's exactly what we're trying to calculate is, you know, when do you need to do these tests so it's most effective?
Great. I want to thank all of them again. They can't hear everybody clapping, but I can tell you that people have already sent notes. It's wonderful. I appreciate you folks doing this. Golda, thanks so much for moderating the session. Hopefully this is a format that is working out well. We're still figuring out how to do online seminars well enough, where everybody has a chance to participate, but we can take care of the background noise that sometimes might happen. Couple of just notes. I just want to remind everyone who is part of the expedition's proposal to make sure you cite the grant. It is important for us. And I think Golda has, can you tell us who the next set of speakers are? Because I think this way people know what to expect.
Yeah, in 2 weeks, 2 weeks from today on July 23rd, we have Aditya Prakash from Georgia Tech. He'll be giving a seminar then.
This is great. I think seminars have taken off in a very, very good direction. So pleased. So if no more questions, then let's close this particular meeting. Thank you very much, Abhishek, Alison, and Jeff for speaking. Thank you, Golda. And thanks to everyone who participated and attended. Please feel free to distribute the invitation that Golda sends. We have now bought an account which can allow up to 1,000 folks join in. I don't think so we'll ever get 1,000 folks, but the point is that essentially we have no limit on number of people who can participate. That limit is taken off. So feel absolutely free to share this link with others who might be interested in joining.
Also, if anybody would like to join our email list specifically for these this seminar series, I put the email address in the chat box. It's GPCE_seminar_series@virginia.edu, and I'll get you signed up for that.
Thank you so much, Golda. Thanks, everyone. And we'll see you in 2 weeks from now.